Good evening and thank you everyone for joining us today. This webinar organized by SIG Endoscopy of Indian Fertility Society with academic partner Nari Division of Jagsonpal Pharma Ltd. Makers of EndoReg, DeeReg and DeeReg. We have convener Dr. Punita Bhardwaj, madam. She is an expert in endoscopy practicing as unit in charge senior consultant at Sir Gangaram Hospital, New Delhi. The co-conveners are Dr. Priya Bhave and Dr. Maansi Jain. Dr. Priya Bhave is Secretary, Indian Fertility Society, MP chapter. She is consultant and head reproductive medicine at Bansal Hospital, Bhopal. And we have Dr. Maansi Jain, SIG Endoscopy, is consultant reproductive medicines at KJ IVF. Now I request conveners to please start this session. Thank you.
Thank you very much, Amit. I would like to thank Jagsonpal for kindly supporting this academic initiative. I would like to also extend my thanks to Indian Fertility Society for giving us this opportunity to discuss on this very, very important topic. We are pleased to have with us Secretary, Indian Fertility Society, Dr. Surveen Ghumman Sandhu. Professor Surveen does not need any introduction. She has been serving as the Secretary of Indian Fertility Society for the last 2 years, and her tenure has been a very vibrant and a very, very academic one. She is one of the most academic reproductive medicine specialists of the country and is keenly interested in research as well as in sharing of evidence-based information. She has served various responsibilities in different organizations, and to her credit is writing up the first Indian evidence-based guideline on poor ovarian reserve. She has also received multiple awards like the IMA Excellence Award, like the IMA Summit Icon of the Year Award, Satyapal Award for the Best Review Article, Entertainment Times Award, and the list is endless. Welcome, ma'am, and we really thank you for your patronage. Dr. Punita, our SIG convener, is also here, and I would like to hand over the proceedings to her so that we can listen to Dr. Abhishek on his topic. Thank you so much.
SIG Endoscopy, like you all know, is a specialist interest group in the IFS, Indian Fertility Society. And I'm the convener for the past 2 years, and we do these activities. And I think we should just start with Dr. Abhishek Mangeshikar. So Abhishek, he is doing a lot of great work in minimal access surgery. He is the head of the minimal invasive gynecology SEPI hospital. He is also the head of Endometriosis Center, Jaslok Hospital. He is a zonal coordinator of Endometriosis Society of India and currently serving on YAG board for Apache. Level 2 neuropelviologist, International Society of Neuropelviology. He has a fellowship trained from Apache in minimal invasive gynecology. Abhishek, I think you have a bright future and you are already doing so much of good work. So can we have your presentation, please?
We will talk about this. This is a very interesting and also slightly controversial topic about colorectal endometriosis. And why it's controversial is because we don't have consensus between gynecology, surgeons, general gynecologists, surgical endometriosis specialists, and the fertility specialists. So hopefully we'll try and find some middle ground over there. Okay. So I'm going to start with this short video so you can understand where the problems with consensus comes in.
Never coming round. Turn around. Every now and then I get a little bit tired. Listen to the sound of my tears. Every now and then I get a little bit nervous, like the best of all the years have gone by. Around. Every now and then I get a little bit terrified, and then I see the look in your eyes. Turn around, bye, time. Every now and then I fall apart. And I need you now tonight. And I need you more tonight. And if you want me inside, we'll be holding on.
So that's just to show you the amount of problems in consensus and diagnosis that the average endometriosis patient with colorectal endometriosis goes through. The ability of the radiologist to diagnose this disease is minimal. Very few of them can actually make the diagnosis. I've seen very large colorectal nodules come back with reports saying the colon is normal, and it's often mistaken as feces. Pregnancy cures endometriosis patients are still told that, yet there's not a single document in evidentiary medicine to support that statement. A lot of symptoms are gaslit or diagnosed with IBS, which is a diagnosis of exclusion, which means that there is no pathology causing it. But endometriosis in the bowel is a pathology which is missed. So it's diagnosed as IBS or misdiagnosed as IBS. And then you have a lot of other problems pushing pregnancy, pushing hysterectomy. So we have no consensus. In the treatment, this was created by a friend of mine, Shaheen Khazari, where you have these camps in endometriosis. Those who believe you should not operate, they believe surgery is never the answer, give drugs and hope for the best. And on the other end of the spectrum, you have the treat it like cancer camp who did radical hysterectomies and bowel resections on all patients, even for the tiniest of nodules. And somewhere in the middle, you have incomplete excision, which they say if you remove some, the rest will go and medicine will take care of it. Ablation camp, which is burning or fulguration of lesions, which you don't know how deep the lesions go. So they say there's no evidence to support one or the other. So we do what's easier. And then one should always strive towards the green camp, which is to achieve complete excision of the disease, but to remove that completely within reason, taking care of things like ovarian reserve, fertility potential, nerves, patients' neurological outcomes, and functional outcomes, etc. So this is a common scenario most gynecologists would see in their daily practice, where a 30-year-old comes in with deep endometriosis, pain on dyspareunia, dyschezia, some bowel symptoms possibly. And then she's presented with this dilemma of what is your priority? Would you like to relieve the pain, or would you like to get pregnant first? And then the patient says, okay, I'll get pregnant first and deal with the pain later. And then she's put into one or multiple IVF procedures. The question itself has a fallacious notion, which means it suggests that the two goals of treatment cannot be attempted simultaneously. Now, we know, and there is enough evidence now, that excision of the disease not only improves your pain, but also improves pregnancy rates, which means natural pregnancies as well as ART outcomes. So if you look at work from Horace and many other colleagues in the field from the US, now there are a couple of papers also coming out in support of this, that shows that excision surgery for colorectal endometriosis allowed conception rates of around 80% within the first year. These are infertility patients with colorectal disease. The pregnancy rates were 80% within the first year after surgery. And out of that 80%, 60% of those were natural. So a lot of natural pregnancies, and the remaining percentage required IVF to have their outcomes. What we need to understand is for colorectal endometriosis, this is completely different from any other colorectal disease. For any other colorectal disease like cancers or Crohn's, this disease grows from inside out, whereas endometriosis grows from outside in. So it grows pretty much through the serosa and the muscularis, and very rarely into the mucosa of the bowel. So why do we need to understand this? Because we see it most commonly in the rectum and the sigmoid colon, almost 80 to 90% of the time. But we also see it frequently in the appendix and the small bowel, the ileum, and also at the ileocecal junction. So it's very important to be able to identify higher up in the abdomen and not just the pelvis. Extrapelvic disease is not rare. Now, why I talked about it's the only disease that grows from outward in, because a lot of patients with bowel symptoms may be subjected by the gynecologist or even to the gastrointestinal surgeon when they go to them to colonoscopies, and they always say the colonoscopy is negative, so you cannot have endometriosis in the bowel, which is a big misconception, because when we look at the data, only colonoscopy failed to diagnose endometriosis of the bowel in 92% of patients. So it has a sensitivity of 7%, which is worse than flipping a coin for this. So it should be discarded as a diagnostic tool for endometriosis. And the study showed that the colonoscopy will only pick up nodules invading the mucosa or the submucosa, or huge nodules causing occlusion of the bowel. So it is not a good diagnostic tool. And this comes in a problem when there are colorectal or GI surgeons leading this because they believe the colonoscopy is the ultimate diagnostic tool for everything, but they don't understand endometriosis. So it should be gynecology leading the discussion, and they come in and play their supporting role as needed. Now, when we talk about bowel endometriosis, it's not one size fits all where we're going to do a resection for every patient or shape for every patient. Those days are gone, and I hope that consensus has, we cannot have these debates anymore in conferences or should we only do shaving or should we only do resections. If you're doing endometriosis surgery, you should be able to do all of them depending on the type of lesion. So shaving should be restricted to lesions not too deep into the muscularis and not really invading into the muscularis more than a certain depth. For lesions that are smaller, then I would change this. I would say it's like 4 or 5 centimeters now because you can manipulate that with less than 1/3 circumference of the bowel included. Okay. And there is full thickness infiltration into the muscularis or deeper, then those patients can have a discoid excision, which is a removal of just the anterior wall with no disruption of the rectal ampulla. And for lesions that are bigger than 5 centimeters or multiple lesions in close proximity, or those with more than 1/3 circumference involvement, or those that are causing subocclusion where nothing can get past the bowel, then those patients should be reserved for segmental resections. Okay, so I'm going to talk about each of these techniques and hopefully we'll understand that. And if I will be able to answer any questions later on. So the goal of shaving is complete excision with bowel conservation. Means we do not make a hole in the bowel. Now you can use whatever tools you want. You can use scissors, laser, harmonic, scalpel, plasma jet. And it is the excision of macro and microscopic lesions. It is most likely incomplete no matter how complete you feel you may be, you're always going to leave some degree of fibrosis behind. So that means it's got a low rate of complications, of course, but it has a low rate of functional outcomes because you're not going to have any nerve damage from shaving a nodule. And your long-term recurrences is probably highest. So it's about 6% overall. And it's a first-line technique when feasible, and possibly patients are going to be, not undergoing many hormonal therapies later on, or if you're going to be amenorrheic or something like that, then maybe it is a final technique in order to avoid recurrences there. So if you see a shaving video, you see this nodule here, and when we start shaving, you can see the layers of the muscularis kind of peel away as we go through. So we're not breaching the mucosa, but you can shave even when it's somewhat involving the muscularis. So starting from the bottom of the nodule, I'm basically just kind of getting a plane there, and I'm going to run a ring around the nodule itself. So just to demarcate it and move all the healthy bowel away. And this is a pure cut monopolar settings on the Da Vinci robot. I do laparoscopy and robotics, and I'm going to talk about the advantages of both. So here is where the nodule was. You can see this area now, and then we moved it away and just continue shaving across now. So once we have fat, that's not actually the rectum, that's the mesorectal fat. So once you clear the nodule itself and you're getting away from the fat, and the blood vessel is the blood vessel that hides in the fat, that's why it's bleeding, then you're pretty clear of your rectum and you're not worried about running into the bowel wall there. So then you can just take all this infiltration of the fat and the pelvic side wall where it was stuck off, and then the shaving procedure is complete. So that's how shaving is done. Like I said, you can do this laparoscopically or robotically. They're both fine. It should never be done by open surgery. That is a ridiculous approach for endometriosis. Here, when we put a rectal probe in, you can see this is the area where the nodule was, and it's shaved, no denudation of the muscularis, so it is doesn't require suture. Of course, if you do shave deeper, you do need to take a stitch. Now, what's important is that it is an unstandardized technique. Different surgeons do different shaving because a lot of them may underestimate the disease. So we should always have a good preoperative assessment of the depth of the lesion before shaving. So you see a lot of these cases that I had were shaved previously, and these are very deep nodules. This is a subocclusive nodule that somebody tried to shave. So when you start shaving these nodules, what you're only removing is the serosal component of the disease, but the disease inside the muscle gets left behind, which is actually the more symptomatic thing, which is a problem in the first place. So there are many nodules that should not be shaved in the first place and have not recurred. This is persistent disease. So that's what we need to understand. It's not a highly recurrent disease if the disease was never removed in the first place. Now, a disc excision is one of my more favorite procedures. So you see, you have a circular stapler where it's inserted into the rectum after we have shaved it down and taken a stitch proximally and distal to the nodule. And then the laparoscopic surgeon pushes those sutures down while the stapler is open, and we remove only this nodule in the anterior wall down here. So there is a full thickness excision. So this was how it was done originally, where laparoscopically they made a hole in the bowel and then sutured it closed. This has much higher leak rates. Now it's done with a circular stapler transanally. So just to show you diagrammatic, if this is the lesion, we take a stitch proximal and distal to the lesion, and then use the ends of the stitch while the colorectal surgeon inserts the stapler with the anvil in place and opens it under vision. And then we push the nodule inside. Now you see that's how it looks in sagittal view. Push the nodule inside, and then the stapler is closed and fired. So only this wall is removed up here. So this little cross-section diagram shows how it works. So basically you're removing like a calzone pizza, which is a disc. And when you look at specimens like this that we remove, you are wide, clear margins. And when you look at a cross-section, you can see it's involving the full thickness of the muscularis in all dimensions over here. Okay, so the advantages of this is there is no bowel denervation or loss of length or volume of the rectum or the sigmoid, rectum. You can't do this for sigmoid. And the cons are that you can only do this for single nodules less than about 4 or 5 centimeters in size. Bigger than that or more lateral spread than that, then you have to do the resection. So this is an example. This is a great example. So you see, you don't need to be a robotic surgeon that you can tell that you can see there's a nodule there. I have shaved this before to reduce the size, but although it looks very healthy in this thing, when you do a squeeze here, you can also see that there is a nodule inside and the healthy bowel below. This is very important because a lot of, the laparoscopists have the same arguments that the open surgeons had a long time ago and said, you cannot feel anything at robotic surgery because you've lost your tactile, but you can visually see it. You don't even need to be present during that surgery. I think anybody who is maybe even never sat at a robot can tell that there was a nodule in that area that was held up. So I think that argument should be kind of laid to rest, because there was literally the same argument the open surgeons had with the laparoscopic surgeons about 30, 40 years ago. So like I said, we take the stitch proximal and distal to the nodule. Now the colorectal surgeon will introduce the stapler through the anal canal. So that stapler is passed here. And now the anvil is opened under vision. So when the anvil is opened under vision, whatever's coming between these two is going to be in our staple line. So then we tie a knot. So whatever's in between my two ends of my suture is going to be resected. And that's the colorectal surgeon closing it a little too enthusiastically before I could pull the suture down. So we're going to take that again. And yeah, now that's closed. And now he's going to fire the stapler while anteverting the rectum. So it's important to only take the anterior wall and none of the posterior wall is in this thing, because the disease is only anterior. So once that stapler is fired, my knot is obviously inside, so the ends of the suture come free. And then he withdraws the stapler and we have an inspection of the staple line under vision. Always perform the hemostasis of the area, because if there's fat entrapped in there, it can be cause a rectorrhagia. So segmental resections are, like I said, are reserved for specific kinds of nodules. If you have like a big rectal segment like this, where there were about 5 different nodules in close proximity, or if you have these long lengths of infiltration, or a big subocclusive nodule like so, these are examples that require only segmental resection. Now, there is a very, very low recurrence rate. I would argue in like 0.5 to 0.3%. It's very, very low. But it's very important that this patient is followed up well in their hospitalization. In India, we don't have the post-operative period is not very expensive compared to the West. So I would say hospitalize at least up to day 5, day 6, day 7, depending on what kind of procedure. You don't usually leave a drain, and we don't do prophylactic colostomies or ileostomies unless we don't do a drain unless there's hemorrhage, and we never do prophylactic stomas except for very, very ultra low resections, which are very rare. We remove the Foleys on post-op day 1. This is very important. We do a daily CBC and a CRP until post-op day 10. And we watch the white count. And if there is a rising white count or a CRP is raising and crossing 100 post day 4, we suspect one of 3 things. That is either a fistula or a leak, or there is a collection which is forming an abscess, or we have a urinary infection. So we do an urgent CT scan with a rectal contrast to rule out a fistula and also look for the collection. And if there is anything found, we do an emergency laparoscopy and do a diverting stoma at that time. Now, of course, when you do a low rectal segmental resection, you are at the risk of rectal denervation, which can result in a low anterior resection syndrome. So it's very important to not do this surgery the way the colorectal surgeons are trained to do it for TMRE and colorectal cancer. We have to do it keeping the fat and the vasculature and the lymphatics and the nerves intact as far as possible, and just removing the affected bowel. So there are certain techniques that endometriosis surgeons use that have to be taught to our colorectal colleagues. Okay, and of course, if a big resection can also reduce in the reduction of the bowel reservoir, so the rectum is losing its ability to hold stool, so there is frequency and urgency in these cases. The risk of this is about 10% for low anterior resections. Sorry, my screen froze. Okay, so now the technique of what I do for this is I do it in a completely natural orifice technique. So that means everything is done intracorporeally inside the patient's abdomen at surgery. There's no laparotomy made to exteriorize the bowel and to replace the anvil. So this is a very interesting technique in terms of it reduces the morbidity of the surgery, and I think the postoperative outcomes are slightly better. So I'm going to show you how I do it in the video. So we do a side-to-end anastomosis. But before I talk about colorectal resection, I want to talk about the correct approach for this. So there's always been debate about laparoscopy versus robotic surgery. And then, as Americans tend to do, you have wonderful papers coming out like this, like the LaRose trial. And it showed that for laparoscopy and robotic surgery for endometriosis, there was no difference in blood loss, complications, or conversion rates. They did not evaluate differences in cost or recurrence rate. And they had a consensus that open surgery should never be done for DE. Now, the problem with this is when we start looking at the data a little more closely. Now, everybody who's a laparoscopic surgeon quotes this study, but they never read the fine print. When you look at the study, you look at the robotic is 35 cases, laparoscopic is 38 cases. Now, this is from about 5 different centers over 5 years, and they have only 73 cases, which is ridiculous. This is something a normal center would do in 4 months, forget 5 years. And what is important to know is look at the endometriosis selection. For the robotic, 19 out of those 35 were only stage 1 or stage 2. For the laparoscopic, 9 were stage 1 or stage 2. For the stage 3, stage 4 were 10 cases, and 14 were for laparoscopy. But no endometriosis in 21 cases. So anyway, when your cohort is so small and you're using very few cases of complex endometriosis where you're going to see the advantages, and then to draw conclusions from that is ridiculous. So this is quite a failure as a research paper or publication for publication's sake at the end of the day. This needs way more data, and I think so. And looking at that, I kind of analyzed my own data. So this was from February 2023 to, I think, about October or November, October. Oh, we have it right here. Yeah. Oh, sorry, till January 2023 till August 2023. So we looked at our length of stay, which was 5 days for lap and 3 days for robotic. Of course, there were 100 lap cases in consideration then and 35 robotic cases, similar to the LaRose trial, but I mean, not triple the number of laparoscopy, but similar to the robotic cases. Now, the operative times were similar. Of course, I will tell you my laparoscopy cases were a little more complex at that time. So that's why you have your little longer time and a little overestimated blood loss on the laparoscopic surgery scales. But pain scores were lower for robotic surgery because we operate at lower pressures. And the complication rates were 2% and 1%. I would not argue too much there. And all of my cases were stage 3 or stage 4. BMI was also similar, so we're not really looking at those things right now. But to me, the indications for robotic surgery are very clear in certain situations. When you have low rectal disease, the dissection you can perform by the robot is much better than laparoscopy. If you have endometriosis of the diaphragm, to be able to suture this defect once it's repaired is much easier to do via robotic suturing than via laparoscopic suturing. Similarly, for bowel endometriosis, large bladder endometriosis, to remove those nodules and reconstruct the bladder, the robot is very useful for that. And when you have endometriosis covering the parametrium involving your sacral nerve roots, this was a big nodule that was compressing these sacral nerve roots S2, 3, and the patient has urinary issues and sciatic pain because these are root values for that kind of thing. Or if you have endometriosis or this thing on the nerve itself, then the robot is an invaluable choice. So basically, for a segmental resection, this is the strategy. You mobilize the sigmoid colon, mobilize and suspend the ovaries, suspend the uterus, or manipulate where you can get strict anteversion, perform ureterolysis, pararectal space dissection, and then dissect the nodule from the midline. So you drop the rectum off the pouch of Douglas. This is not the end of the procedure. Then obviously you have to perform the resection. So this is a very large nodule that is infiltrating the vagina and the rectum. So you can see this is almost subocclusive in its presentation. I made a video for this, which is a little 10-step technique, nose technique for deep endometriosis of the colon. So we see here, this is a huge nodule in that. That is not a manipulator. That is literally how big the rectal nodule is. So once we've identified that, we begin our preparation. The first step is left ureterolysis. So you identify the ureter at the sacral promontory and kind of remove it down. So there's not massive disease in this peritoneum, so it's no need to completely skeletonize the ureter as long as you have eyes on it, because it can disappear into this nodule at this part of the junction. So it's better that you have it under vision early on. And here this little uterosacral is infiltrated, so I'm going to excise that nodule first and get that off, and then proceed with the next couple of steps. Now we dissect the left pararectal space and the right pararectal space. Now this is the Okabayashi space. So we go into this avascular plane, which is a TMRA plane. The lateral pararectal space is here to the right below the ureter. But we use the medial pararectal space for our dissection, or the Okabayashi space. And I use this to kind of guide my way around the nodule, which is up there. So I use this as a guideline, and I use the rectal fat and kind of use the rectal wall as a marker, and use that to dissect upwards towards to get behind the nodule, so to speak. So almost towards the pouch of Douglas, but instead of going through it, I'm going around it. Safe to do that when you're dealing with such a big mass. Similarly, I'm going to perform the same dissection on the right side. And now we're going to prepare the bowel for how much we dissect. So this would be where you separate all the fat of the bowel, which is defatting the bowel, because we don't need to remove the lymph nodes. We don't need to disconnect the blood vessels. So we keep all of that intact, so there's very little damage to the bowel. Now is the most difficult part, because you have to cut through disease. So you have to be able to identify the plane between the nodule and the vagina. So I'm cutting very slowly, one step at a time, and using the healthy space. And once I've cleared the nodule, I get this giveaway. So the nodule is here, and this is just pushing the slight infiltration onto the vaginal surface. So we get a healthy pouch of Douglas there. Now, because there was infiltration in the vagina, I make the colpotomy to start excising the affected portion of the vagina. There's a glove with a pack inside to prevent loss of pneumoperitoneum. And then I finish the vaginal nodule excision. So moving forward a little bit, we finish excising that, and you can use the vagina as the repository to remove specimens. So now the bowel is transected, and we use the open vagina now to introduce the anvil of the stapler. So I'm just going to park that on the side. And now we know how much is going to be resected into where we devascularize it. So you can see the purple area is devascularized. So I'm going to make an incision there. That's going to be where I'm going to insert the anvil into the healthy pink area. So I make a colotomy here. And this patient has been bowel prepped. We do peg leg and we do mechanical prep right before surgery as well, because we want to reduce contamination into the pelvis. So once the bowel is opened, then we push the anvil inwards with the spike in place. Now you see the way I do it in this case is spike down, but I'll show you an easier way to do it. This was an earlier case. And we've kept a suture tied at the end of the spike, which is going to facilitate the retrieval of the anvil after you fired the stapler. So now we've closed it. We make sure that the anvil is not involved in the stapler, and all of the disease, all of the bowel below the stapler is going to be a specimen. So now this is going to close off the bowel once we fire the stapler. And once that's fired across, it's gone, and we'll retrieve the specimen through the vagina. Then we make a small colotomy over here and push. So very important to have the assistant hold the anvil, otherwise it can slip up into the splenic flexure, which is a task to get down again. And then use a Maryland to slightly just identify those threads and pull it out. This can sometimes be a little tricky in a more obese patient. So we've changed the technique a little bit to make it a little more straightforward for retrieval of the spike. Now you obviously have to remove the spike before performing the anastomosis. That's what we're going to do. So we have to pull the spike off. And retrieve it through the 10mm port. And now we get ready for our anastomosis. So we have to close the vagina first. And you can see the staple line is down there. And now we introduce the circular stapler through the anus, and the spike is introduced, and the two ends are mated together. And then we check the orientation of the bowel and then close the thing, and the is fired. Then once we check for air insufflation to look for any leaks. And that's the end of the procedure. Have an inspection, and that's the end of it. Now, it was a very large nodule causing subocclusion. You can see its entire muscularis is involved, big kind of walnut-sized nodule. And to show you another one, this is an infertility. Both were infertility cases. So you have vaginal infiltration there, you have rectal infiltration there. This is a robotic case, similar shaped nodule. I'm going to go through this a little faster, but I wanted to highlight the robotic advantage because this is a great tool for teaching. So you can see I'm showing them where the nodule is and where the healthy bowel is. So, and the reproducibility becomes much more. So, and then your learning curve becomes a lot shorter when you do this. So we've performed the ureterolysis. I use the tunneling effect of the bipolar forceps on the left to kind of protect the ureter. And here you can see the whole peritoneum is diseased. So we remove all of that as well. This is also going to reduce recurrence rates as well as reduce inflammation, which will improve the fertility outcomes too. So it's very important to remove all the disease and not just the big stuff you identified. Again, there's a small cyst in the right ovary, and you have to remove that as minimalistically as possible without charring the ovary too much and avoiding as much bleeding as you can. That's when said, we move our attention to the right side. So this is a very important trick I like to teach in robotics. You have to be able to switch your hands because your dissection has to move in a particular direction. So you should be able to use the scissors and the monopolar with your left hand and with your right hand. This is very interesting because if you look at this peritoneum here, most of us are trained to just fulgurate this during residency, but actually when you excise it, you see how deep it goes, how thick this peritoneum is. So fulgurating the surface of 3 or 4 millimeters is not going to make any damage. It has to be excised and removed. So we should really abandon, fulguration, or ablation of the lesions that may look superficial because we don't know how deep they actually go. All right, so once that's done, we start moving our attention towards the bowel. So you see I get into a nice plane here behind the nodule. Again, continuing with my left hand with the monopolar, and now I switch them back and start performing the pararectal space dissection on the right, removing this affected uterosacral peritoneum on the right side, continuing that dissection, and now using this. So you can just use the traction of the bowel to push down, and then suddenly you get the give way, and that's the healthy pouch of Douglas. Now, this was a very interesting nodule because it was low, and you see that's where the nodule has been dropped off. That is the cervico-vaginal infiltration that's still there. I was planning to try and do a disc excision because it was low, and you'll see that that failed, and I had to convert to a segmental resection. So you have to be able to counsel the patients for everything and do what is needed to get the disease out. So first, I'm just shaving, and I'm going to try and determine at which point I want to attempt to bring up the vagina. So here, because I was planning a disc, and I want to say that a circular stapler can only accommodate 8 cubic centimeters in volume. And as a surgeon, the length and laterality of your nodule is not under your control, but the thickness of the nodule is. So that means I can shave it down as thin as possible, and that was going to help me pull off a bigger and bigger disc. That is why the criteria for disc excision has changed from 3 centimeters to maybe 4, maybe 5, depending on how skilled you are at a deep shave. Now, I've realized that I cannot even get this stapler or rectal probe past, so I'm preparing the bowel. So this is done very easily just with the monopolar and the bipolar. So the fourth arm of the robot is just suspending the bowel for me, and I just go and defat the bowel literally. Now I make the colpotomy, and you can see the infiltration down here, those purplish lesions. So I excise the affected part of the vagina and now have the vagina open for my use. Now we make a colotomy higher up, and now we use the spike inside out. So this is much easier, and we don't waste time retrieving it. And then just slide the base in, and we fire our stapler across here. This is a little simpler way to do it. You can do this laparoscopically as well. I was just showing you my process of how we evolved in the technique. And here, this is the distal limits being fired of the rectum. So whatever is above the stapler now is specimen side. What's below is going to be our anastomosis. So that's retrieved through the vagina. Now we close the vagina. That's very straightforward with running continuous, and then perform the anastomosis one last time. Check the orientation, fire the stapler. And here I'm saying there's a little exposed area. So I'm just going to run a suture through there to imbricate that, and maybe place an adhesion barrier here because we have a vaginal line right over our rectal staple line. So as a little added safety precaution. And then, of course, we do our safety tests with air and with methylene blue if required. We test the tubes and remove peritoneal disease over the bladder. And that's the end of that procedure. So this patient has been advised 1 year of natural cycles to try and get pregnant naturally. If that fails, then she is going to be recommended an ART procedure. So we put an adhesion barrier there just in case. And that's the end of the procedure, just showing where the staple line is. And here you can see the nodule in our cut specimen right there. The last one is when you cannot open the rectum. I mean, when you cannot open the vagina, what you do is, so this is a very young girl. I place the suture of Vicryl and then use that to suspend the uterus to the anterior wall. So just use a suture passer and pull it through. And so that's fixed to the abdominal wall. You can see this big nodule down here. There's a laparoscopy, opening the left pararectal space. I'm going to go through this a little bit faster because I think we're going over time. I'm going to suspend the ovaries, perform the same procedure on the right, and start preparing the bowel shortly after this. I'm going to dissect the space. You can see the hypogastric nerves over there quite well. So this is always pretty much a nerve sparing procedure. And as long as the nodule is not too low, you're not damaging it too much. So you can see the hypogastric nerve right down there. And underneath there are the pelvic splanchnic nerves, which we have to be careful for because those provide voiding function and sensation of the bladder. So just to finish the midline dissection, at this point, I like to use bipolar and scissors because it gives me a little finer dissection. I find that the ultrasonic device does create a little bit of sealing of the tissue, which I don't like in my, it makes the dissection a little more hard. But once I get the giveaway of the nodule, then I'm happy to switch to the thermal device because it reduces the bleeding that I would normally encounter with cold cut. So you see healthy bowel back there, and that is almost cleared. So the lesion is quite far away from there. So we got a good space. I'm going to run through these steps. We've seen how we prepare the bowel. We make a window under the mesentery here, and then just run it parallel to the bowel. And you're taking away all the fat, which is going to make your anastomotic line a little healthier because it'll bleed less. And now we make the enterotomy above the nodule, below the nodule. So this is going to be where we open. So we make two holes in the bowel right now. So one is where we're going to introduce and remove above and below the nodule, basically. So now we introduce the anvil through the open lower hole, and then turn it around and push the spike upwards through the upper colotomy. Now push this through. You don't want to go too high because we lose more length than we should, and then flip it around and start firing our staplers. So this is going to disconnect the bowel at above the nodule, and then we're going to, this is a very interesting part. So now we have disconnected it both ways by cutting through, and now we have to remove the specimen through the anus itself. So we just pull it through the anus, and now we have to close this. So we fire a stapler across here. So we just lose this little bit of extra, and which is not much, and then pull that out through the 10mm trocar on the right, and then use this to open our stapler and perform the anastomosis. Same thing as before, we do the water tests laparoscopically. That's what the specimen looks like before we cut it. And that's the nodule inside that you can see very clearly over there. So it's very important that we do equitable distributions of procedures. I do a lot of bowel endometriosis. I think 50% of my cases in 2021 involved some kind of bowel procedure, and then 40% in 2022. I haven't done 2023 yet. So I want to say that this is a new specialty. Endometriosis is different from gynae. It's very different from gynae oncology. They are not very well versed with doing this kind of surgery. Our patients are young. They probably live 50 to 60 years after surgery. So it's very important to give them post-operative long-term quality of life. Conservative rectal surgery is feasible in a majority of cases. There are risks of immediate complication which are lower when you don't have too many staples. And we should also be looking at functional outcomes which are comparable using different techniques. So one should be well versed in all the three techniques. I thank you for your time, and if anybody is interested in learning endometriosis, you're always welcome to come and spend time with me in Bombay. And I operate pretty much every day of the week that I'm here, and I do equal laparoscopy and robotic surgery. So you're welcome to join anytime. Thank you.
Thank you, Abhishek. That was amazing. And what a long journey I think we have covered, from cases where, don't touch the rectum if she's infertile, and to extensive surgery, extensive debulking surgery, and having a symptomatic relief. Tell me, how do you counsel these patients? Initially they used to say the fertility patients don't do too much of surgery. Just do the needful and that is it. How do you counsel your patients? Because in one of the cases you said that shaving was not possible or disc excision was not possible, and she landed up in a segmental resection. So I think you must be spending a lot of time counseling such patients, because at that time you can't make decisions for the patient. It all has to be thought of beforehand, of course, apart from having an extensive diagnostic workup.
Absolutely. And that's a very important point I think you brought up. Is one is endometriosis is a very jealous mistress if you take it up as a profession, because you can't do anything else. You cannot do obstetrics, you cannot do infertility, you cannot do onco, you cannot do urogyne. You're only doing endometriosis. So for me, I can see maybe 6 patients in a day, because each consult will last about 40 minutes to an hour at the most, which is a long time. And you have to, one is make, like you correctly said, the diagnostic workup is paramount. You have to be able to counsel them that, yes, I will try and be as conservative as possible on the bowel, but there is a case that if I cannot do that, I may need to step up the procedure. And that will change how long the patient will be hospitalized. It will change the risk of complications. The risk of a stoma is about 1.7 to 2% for these cases, depending on series to series. I've seen my records are about 1.7 to 2%. I think I've seen reports of about 3 to 5% from most of the endometriosis centers have similar kind of risks of complications. So there's no role for prophylactic stomas when the risk is low. Also, for fertility now, it is pretty much a lot of evidence coming in that these patients greatly benefit from surgery first before going into ART. If you see the second part of the study that Horace has put out, so first he did surgery and first IVF first, and then he showed that surgery preceding IVF had much better outcomes than just IVF alone for endometriosis, the colorectal region.
Yeah, we need to press on this aspect of the surgical cure, because one, the quality of life improves, your pain reduces, your fertility rates improve. So it's a win-win situation for everyone, both the ART, the patient, and the surgical people. And also tell us, Abhishek, how do you go about training yourself for it? You don't start away with segmental resections. You kind of upgrade yourself gradually, like you do in most aspects of surgery. Can you give us the tips and tricks to the youngsters who would want to follow your path?
So training is very important if you want to do this kind of surgery. So my background is I did 2 years fellowship post my post-graduation in minimally invasive gynae onco. There was a gynae surgery with a big focus on gynae oncology and endometriosis and also V nodes at that point in Taiwan. And then when I came back, I originally wanted to become a gynae oncologist, and that failed miserably because nobody at that time in Bombay was doing laparoscopic surgery for gynae onco, and all the big guys were doing only open surgery then. And so first couple of my cases were very badly managed endometriosis cases, and then I realized that I was not doing the surgery that I should be doing, and I was not doing it extensively enough. So then I upgraded. I spent a lot of time with Horace Roman in Bordeaux. I got a good volume of it. And even when I came back and I started, I would send MRIs of my patients to him. I taught myself to read the MRI because a lot of the radiologists were missing the diagnosis. Then I taught myself to do the ultrasound and pick up the nodules in the bowel and everything. And that's how it came about. And then I worked with colleagues. I built a team. I told a couple of colorectal surgeons, urologists, this is what I'm kind of planning to do. Check this guy's videos out. This is what we're going to do. This is how we're going to build and how we're going to work. So we all kind of learned and grew together and developed some of these techniques now on our own. Some of these are some of the earlier, that string technique was the innovation of my friend who's a colorectal surgeon. And then obviously we've changed it now for the robotic approach.
Yeah, because we as gynecologists are very scared of the colon, medico-legally in the court of law, do we have to have a colon surgeon at the back of our holding our backs, or as an endometriotic surgeon you can go ahead and do it on your own after you've upgraded yourself? Is there always a doubt about having the colon surgeons along with the gynecologists?
Yeah, I think that's a very good question. I mean, we have you see a lot of surgical cowboys who say, oh, I do everything myself. And it's not fair to the patient, because Like we have one big laparoscopic surgeon who came back and she called my colorectal surgeon, didn't call me, and tried to fire the stapler and tore the bowel. So he said it was ridiculous. And the problem is, there should not be an ego in medicine when you're practicing this. I mean, I've done so much, but I will always have a colorectal surgeon present.
Right.
I will prepare the bowel myself. I will even probably fire the stapler robotically, and they will help, with the colorectal part of the anastomosis. But what's more important is they will be seeing the patient as well post-operatively, because they are able to pick up clinically much faster than gynecologists. We don't have
Yeah.
that kind of surgical training to check abdomen for this, and
Right, right. So that's so important. The follow-up and the backup is so important. Thank you so much, Abhishek. It was a pleasure to have you with us. And I think what you taught us today will take out our fears about handling colonic endometriosis. Of course, one can't just go and start operating like you. One has to upgrade and learn, and then gradually step up into a domain which is by far not very many people are attempting straight away. Thank you so much.
Thank you for inviting me. My honor and pleasure to be here.
We welcome Dr. Sonia Malik. She is the director and HOD of Nova South and Fertility and IVF, and she's held so many positions. She's a very, I don't think she needs an introduction, do you, Dr. Sonia? You've been an associate editor, Southeast Asia, Journal of Global Health, IFS, member editorial board, Fertility and Sterility India, member editorial board, Journal of Reproductive Health and Medicine, editorial board, Journal of Fertility Science and Research. So past editor-in-chief, Journal of Midlife Health, scientific collaborator and reproductive research center at Cleveland Clinic, USA, and member of ICMR task force on genital tuberculosis. My God, that's a very, very illustrious career. And it's an absolute delight to have you with us. Welcome, Dr. Sonia.
Thank you so much, Punita. It is really, I would say, a surprise to me when you called me for this particular thing. Thank you so much for having me here. I witnessed the most amazing surgeries just now, by Abhishek, and it was a pleasure to see this. Really a pleasure. Thank you so much. And Abhishek, you look so much like your father.
Yes, of course. His claim to fame is not only that, he's doing a wonderful job.
Yeah, just like him.
Yeah. And Dr. Sonia, needless to say that you are so humble and your achievements sit so lightly on your shoulders that nobody who meets you will realize that the kind of field of work that you've achieved. Tell us about your beginnings. Where did you graduate from? Where did you do your post-graduation from? And how did it all start?
Well, I'm a graduate and postgraduate of Medical College Rohtak. So, and basically, I came to Delhi after I got married. My husband was my batchmate, and he was in Lady Harding when we got married. He was a resident over there. So
wow.
After
I'm a Hardonian. So
you are a Hardonian, okay? Which batch are you?
86.
Probably he was your resident. I don't know. He was Sanjeevani used to be his house surgeon, so I don't know which batch it is. I know that
I was much junior.
So we would have left. So
yeah,
went to the Middle East, and I came back from there. And my getting into fertility was it was a very nice, I would say, a change in my career in the sense. But of course, I had been doing a lot of infertility work even in my postgraduate days. My thesis was on infertility.
Oh, wow. Okay.
Yeah, I worked on the cervical factor in infertility at that time. And it was basically because of that you when you are doing one particular thing and studying about it, then you get interested in
it. Yeah.
And that was about the time when Lucy Brown was born. I'm talking about 70s.
Wow.
So at that time we only had clomiphene with us in our armamentarium. All we used to give was OCPs, Even clomiphene was difficult because our professor used to say, oh, it can have many side effects. Don't give it to the patient.
Ovarian, yeah, ovarian
We had no
tumors.
ultrasounds, nothing.
Yeah, right,
We've
right.
seen so much, Punita, I
Changes.
sometimes feel blessed, we've seen all this transition, all this change from 0 to, I think we've come to 100 now during my lifetime.
Wow,
yeah,
because at that time, fertility was not a separate branch, everything was
absolutely.
a hash up.
Nothing at all.
Yeah,
that's the
and
thing, yeah.
you have seen it progressing from, like you said, 0 to 100.
0 to
And
100.
it's amazing that your thesis work was on fertility, and that's how you got inclined towards fertility, and that's
I
how
set
you
up I
self.
set up the fertility clinic in the college. I set up the fertility clinic because basic whatever we had at that time. But of
Right.
course, at least the file, and to note down what is the patient's complaint and to have a proper infertility file. So that was that is how we started. And then I went to the Middle East. I was in Basra Medical College. I was teaching there. And again, I set up the fertility clinic over there as well. But
Wow.
there we had an ultrasound machine and we were a little better than what we were in India. So although we were not so familiar with the physiology of the reproductive system, we knew nothing about that on ultrasound especially. And we only what we read was in the books that we had read. And that too was not as good as much as we know now. We know so much about our hormones. We know so much about what is happening from day to day, the changes that take place in the woman's body and the man's body, which we were not aware.
Yeah, so
Yeah.
it practically boils down to that you people were pioneers of
Absolutely.
reproductive
I agree
medicine
with you. Yeah.
in India, and you struggled to set up systems
Well,
and guidelines and steps to be able to reach to a certain diagnosis and to manage those cases and to get results.
yes.
So
Yes.
how did that go about? When did you come back from Basra?
So I came back in 1986 when I was expecting my second child. And
Okay.
so there were no schools over there. So I had to put my son in a school. So we came back. I came back from Saudi Arabia. From Basra, I shifted to Saudi Arabia. And from
Okay.
there, I came back. And it so happened that Punita, I started my practice from the backwaters of Delhi. You know,
Wow.
I had no godfather, no godmother in Delhi. So there was
Exactly,
nobody,
exactly.
yeah.
That's the point I'm trying to drive home. That nothing, no background, no
Nothing
support,
at all.
no
Yeah.
mentoring. You
No
are
mentor.
all self-taught. You
Yeah.
just followed the path of your interest, and you
Yes.
build up such a beautiful practice. So this
It's
is what
interesting.
I want to encourage the youngsters, that they said we have nothing, we don't have
Yes.
a,
Yes.
system in place. Now there is so much,
There
you
is so
know.
much.
There is
We
so much to fall
resources.
back on and to begin. So that's
Absolutely.
okay. So you
So
started in Delhi.
yeah, I started in Delhi and I was practicing everything, obstetrics, gynae, everything. And then suddenly, this opportunity fell in my lap. I was always interested in infertility, and Dr. Nalini Mahajan was wanting to go abroad and train in IVF. So we
Okay.
met in a conference. It was Providence, I would say. We were sitting, I didn't know her. We didn't know each other. There was a
Okay.
common friend, the three of us were sitting there, and she happened to, we all were listening to some lecture. I don't remember who was lecturing at that time. It was a conference which was arranged by Dr. Sheila Mehra.
Okay.
It was an RCOG conference, yes. And all three
All
of us were sitting there, and then Nalli suddenly said, I want to start an infertility center in Delhi if I would get people. I said, look, whenever you want to do it, call me because I'm very much interested. I would like to join you.
wow.
Are you serious? I said, yes, I am. And we all forgot about it because I thought, she doesn't know me. I don't know her at all. Yeah.
Right. You just meet and forget.
Yeah,
Huh?
that's it. And after a
Yeah.
couple of days, I got a call from her saying, are you
Okay.
still interested? I said, yes, I am. So she said, come and meet me. So then I went and met her and she said, I want to go abroad and train as an embryologist. And
Okay.
yeah, and I want you to, if you can join me, then both of us can do this together. So therefore,
Right.
it was something, it was like a,
God sent.
godsend, and it was a lottery for me. This is something that I had always desired. I wanted to work in fertility. And
See.
having to work in an IVF center, my God, it was a dream come true. So Nalini
Right.
went abroad for a year and I looked after her practice in her absence. And, I was
Okay.
doing the usual things. And and she said, look, since I'm going to be in the lab, you train yourself in the clinical methods. So
Right.
my sister lives in San Francisco, so I went abroad to her place, and I looked around for all the IVF centers in that area. And I
Okay.
happened to find this old gentleman called Dr. Chetsovisky. He's a
Uh-huh.
very low profile person, but with very good, amazing results. And he was close to her place of residence. So I went and trained under him. I
This is
learned
providence. This
this
is
is problem.
providence.
You know, when you look for something, you find it. And
Find
you know,
it
yeah,
exactly.
it's
What a line.
yeah.
What an inspirational line. When you look for
No,
something, you find it.
find it, yeah.
Exactly. Gee.
So I was, you know, sort of, I was so, by the time I was really, really passionate about doing something. And then, you know, Punita, there was another thing that drove me towards it. My sister was struggling to have a child. My sister who lived in the United States,
San
she was
Francisco.
also struggling. And I was all the time reading to try and help her. And
Wow.
when you read, you learn, you know.
Yeah.
So I was learning
Exactly.
at the same time. And then I would apply it to my own patients. That's how it also came about. So,
Yeah.
and this training in the US, this very short training for 6 weeks every time I went twice for six weeks. And he was a person who would tell me, you sit with these files and don't do anything. Just sit with these files, and in the afternoon, we'll discuss it. That's
Okay.
it. I never went into the OT because that was not permitted, but he did show me the embryo transfers because that was done in a room next to his chamber, and I would see it. But I never witnessed any OPUs, nothing, no ovum retrievals. I never went into that OT. That was not permitted. So therefore, I had to learn that, and we had to start the IVF unit. So I went to Dr. Indra Hinduja, and
Okay.
I went
Wow.
to Dr. Sadhna Desai, our pioneers, and they were
Gee.
so kind. They allowed us inside. They allowed me, and I spent some time over there, learned how to do the retrievals. Of course, I was an observer. I was never given the retrievals to do.
Hands-on. Yeah.
But that was enough, you know. Basically, I was doing a lot of interventional ultrasound before that. I had a small machine, a small one, portable one, but with a vaginal probe. I had bought that because I was interested in fertility and had it in my own clinic. So I knew how to, you know, aspirate for these cysts, ovarian cysts and things like that. I was doing ultrasound guided MTPs also. So I was aware of
Familiar
machine
with the machine.
work. Yeah, I could do it. So then
Right.
when she came back, she set up the lab. So we both started together in her hospital. And then eventually Nalini grew, and yeah, I also kind of had my own practice. So then I moved out of that. We separated kind of. And then
Right.
I ultimately set up my own center when, you know, in 2001. And
Wow.
from there on, a new journey began.
Yeah. And what a journey. And what
Yeah,
a achiever you have. And
yeah.
you didn't tell us about the pitfalls.
Oh my
Uh,
God.
what was the
Pitfalls.
problems that you actually faced? This looks like a dream run.
No, it
I'm
wasn't,
sure there were
believe me.
obstacles, there were setbacks, and how did you overcome them? And how would you inspire these youngsters who want everything on a platter? You had nothing, you just made your inroads into your passion, and how
Yeah.
you recreated whatever you had in your mind. Like you said, when you seek, you find.
Yeah. First of all, is, you know, you have to have the feeling that, see, I was lucky. I mean, I'm not saying myself, but most of us come from families who have been very satisfied. You know,
Luck
most,
favors the brave, Dr.
yeah,
Malik.
that's also
Luck
true.
favors the brave. There's nothing called luck. I think you
Yeah.
create your own luck, you make your own
Absolutely,
luck.
you create your destiny as well, you know. But sometimes
Right.
unforeseen circumstances do cause a little bit of a not little, I would say a lot. I had a major setback. I lost my husband suddenly in 2000. It was, you know, I mean, I'm now in 24, so it's so many years since he's gone.
Now
And
you can talk.
I set up my IVF center after his death. So basically, you know, yeah,
Wow.
this journey has been, I feel so sorry he's not been a part of it. It would have been amazing if he was
I,
there.
I'm sure, but you could
Yeah.
manage because you were hell bent that I have to make a life out of this.
Yeah, I had to, you know, basically for various reasons one does it. And then, you know, basically when you come from a family of we have a very educated and family who's always been teaching. You know,
Right.
I have everybody in my house was my mother, my aunties, everyone, you know, and
Okay.
my father's side were doctors. So, you know, that combination was great. I saw
Deadly.
education all around. I saw education, and I knew that I had to make myself work and do well. So for me, practice has not been, I never did it to earn money. That was not my intention. That is something that I want everyone to
The side product.
understand and know. You know that they have to be patient in
Exactly.
what they are doing. I mean, like look at Abhishek now. He said just now that he went here and he went there, and finally he was able to train himself to reach that level. So
Level.
everything takes time. What is
Yeah.
happening today is that people or our youngsters are wanting to do everything in a jiffy, as the Americans would say,
Exactly.
in a jiffy.
Yeah.
You
And
just
everything
want
on a
to
platter with no,
platter.
yeah,
Yes, no hard work.
no
So
hard work.
the worst thing is that our gynecologist youngsters are now shying away from obstetrics. And they don't understand that all this that we are trying to teach them or tell them about IVF or anything to do with endocrinology
Ultimate result is
or surgery. They just shy away from obstetrics because basically they don't understand that that is one branch of science which tells them how to take immediate decisions.
absolutely.
Instant decisions. Your two lives are at stake, the mother and the baby, and you have to look at, you have to save both of them. So that is something that everyone should understand and take training in that, because that instant decision making is something that helps you to do anything later in life. You can take a decision as to this is right, this is wrong, and cut. I do this and I do that. Even
Right.
now, when I'm doing an embryo transfer, I tell my fellow, look, you drape this patient as if it was fetal distress. Don't take 10, don't take 10 minutes to drape her. So
Exactly.
that
Yeah.
basically, yeah. So for me, it has never been, I never practiced to earn money. It was for my own satisfaction, I think. I wanted to train as a doctor. I wanted to do fertility. I got an opportunity. And that little, thing in my mind that I have to do well is probably what has driven me. That
Yeah.
is what has driven me. And,
And I money
what is
the
success eventually? What is success for you? What
right.
is success for me, for instance?
Yes, Stella.
It is not just to earn, to say कि अच्छा मैं मेरे पास तो ये गाड़ी है, ये बंगला है. For me, it is the patient's satisfaction that is my
Exactly.
most.
Exactly. Yeah.
We were lucky to be taught by doctors or our professors who always said to us, the person sitting in front of you may be your sister, maybe your relative, or she may be your mother, anybody. You have to look at them with that compassion. And I think that is something that has to be there in every doctor
Doctor.
today. Yeah.
Yeah. Come what may. Come
Come
what may.
what may. Come what may.
I feel money is a side product of what you actually want to do. Money
Yeah.
can't be main driving force.
Exactly. And when a patient returns to you, even after a failure, in IVF, we have so much of failure. And we have, I tell my patient, so many times I tell them, this is one of my favorite lines, कि अगर मैं तुम्हारी तरह सबके लिए ऐसे ही सोचने लगूँ ना कि ये पास होएगा या फेल होगा, तो अल्टीमेटली आई विल ऑल्सो बिकम लाइक वहीदा रहमान इन खामोशी. मैं भी पागल हो जाऊंगी, बिकॉज बेसिकली देयर इज सो मच ऑफ tension and so much of
Yes.
pathos over there, and so much of negativity, because the patient is so stressed, she doesn't think positively.
Yeah.
In order to give them that kind of a support is so important, and you have to be very, very positive about what you're doing.
Exactly.
पॉजिटिव होना भी है, और उसमें ये भी साथ में रखना है कि तुम गलत नहीं हो. You have to, like you said, methodology, recommendations, our guidelines, all that we have to stick to it. We
And
can't
balance.
go here and there, because basically we are answerable to the patient.
Exactly.
And they must feel that whatever we are doing is genuine. That is,
Right.
we know
Yeah.
we are genuine. We know that we are, but it has to come across to them
It
as well.
comes across, Dr. Malik. I'm sure your patients understand that this lady is trying to help us, and she's doing all in all whatever she can do to benefit us. And
Punita,
that is
I try my best that they understand.
I'm sure that's why they flock to you, madam. That is why they flock to you. The genuine people, the patients can understand. The
Ah,
and the effort the patient can see.
mm,
You can falsify only once. After that, the patient will not come back to you. You understand? The very fact that the
ab-
failures are coming back to you
yeah, That is my biggest certificate, I think, that, you know, if a patient comes and does 2 cycles after failing or 3 cycles, currently we've got 2 patients who are doing 11th and 12th cycles with us. So, I
Wow.
mean, that is so gratifying. Look at the confidence and faith that the team has generated. You know,
Wow.
everybody, it's not just me, but my entire team, I would give credit to everyone. But the thing is that we have taught everybody to be ethical and transparent in their
Yeah.
dealings with the
So
patient.
you are
That
the
is,
ones spearheading the
हाँ,
whole thing. So
हाँ.
it's
So, मतलब,
leader
you are
on the
answerable to your own conscience. You're answerable to your own conscience. तो कैसे करेंगे ना?
absolutely.
I've started getting patients, my treated patients' daughters and sons for fertility treatment,
Wow.
which
Love
is indeed. I know I know I'm a grandmother. I know that. But basically, to have that kind of a confidence and them bringing back their children to me is even more satisfying. So
exactly.
these are some things that help me to feel that I am successful. Sometimes
Right.
I feel depressed, you know, I see people, there are other consultants across all of us, you know, we see them, they are doing much better than me. I know that everybody is. There are so many people who are doing better.
I
But
think
then,
comparison is something which you should set away.
yeah,
You are
absolutely,
running your
absolutely.
own satellite,
Yes, yes.
your own path, your own breakthroughs, your own difficulties, your own conditioning, your own situations. So no consultant can be similar. And the measure
Exactly,
of success is, I
exactly.
think, the internal satisfaction and gratification that you get, rather
Yes.
than, like you said, that bangla hai, gaadi hai, sab hai, magar
Yeah.
अगर पेशेंट वापस नहीं आ रहा तो कोई पॉइंट नहीं है just to have
हाँ,
your
हाँ.
hours and this
You
thing.
know, no, basically, and every life is different. Your and my life is different as human beings. Even within the family, a sister and a brother or two sisters have an entirely different path of life
Right.
of their lives. They may have come from the same source, the same mother and father, but they have led different lives. We see
Right.
that in our own families, and that happens to us also in our professions.
Yes.
You may be the best, but you may not be the best. You know,
Yeah.
there are
Exactly.
different yardsticks. There are
Yeah.
different yardsticks. So therefore, as far as I'm concerned, I'm quite satisfied because, you know, the kind of the kind of advice or the kind of things that we were told by our parents, you know, not to return any patient, even if the patient comes to you at night, not to return anybody, you know, things like that. That has
Ethics.
stayed with me. That has stayed.
Compassion.
I never ever, I'm always answering calls still. I don't think that I'm a professor, so I'm not going to answer a WhatsApp message or an email message. I always do. Sometimes
Right.
I tend to forget, and then
Yeah.
you know, then you're reminded by your juniors or somebody. But then eventually we feel that no, if we have taken on a responsibility,
Yeah.
patient has come to us with
Responsibility.
some kind of a confidence, faith in
Yeah.
us, we are
Yeah.
answerable. So
Right.
therefore, it is just that. And I think, I suppose you've interviewed so many people and you would have found that most of us are very, very sincere and devoted to our profession, and we
Yeah. You come
do
across
our
as a
best.
very honest human being, and I'm sure
Yeah.
that rubs off on the patient also. Another tip we wanted to take from you, Dr. Sonia Malik, was that a lot of gravitas is there on research work, on analysis, on publications, because we as Indians, I find that we do a lot of work. Our clinics is amazing, but we don't get down to putting it down on paper. How do you facilitate the youngsters to thinking on those lines so that we have more and more publications of our own Indian clinical work? You know, we have a
Let
load of
me-
data.
Yeah, yeah. Let me just tell you that this is, you see, this is ingrained in our genes as far as Indians are concerned. You know, we never wrote. It was R-O-T, ratta, always, you know, not just us. It comes from the Ved. It comes from the Vedas. Everything was, you know, learnt by heart. There was
Art.
very little text.
Right.
We were never taught to write. We were always taught to learn. And that is actually, you know, our minds are so analytical. We have a great sense of logic, all Indians, all of us, you know, but
Yes.
we don't write what we see. That is our Waterloo. So
Yeah.
therefore, you know, now that we have understood that it is important for us to to sort of write everything, or I may say to record everything. Each and everything should be recorded, otherwise we will leave nothing for posterity.
Exactly.
So yeah, until and unless we do that. So you see, when people talk about nice guidelines and people talk about American guidelines, I feel sorry, because we have so much of data, and
Yeah.
yet we don't have our own sort of guidelines to tell us, okay, this is correct for my patient and this is not correct. And
Yeah,
Punita,
because things are different. With
this
Indian
is
patients, things are different from what the Western
exactly. And
are
the
putting
most
down.
interesting part is obstetrics. We are delivering, I think, so many babies every day, and we take the guidelines from other countries, which is
Yeah.
so bad and so sad, which is
Exactly. When
yeah.
when I was visiting the UK, I realized they published 10 cases, 8 cases,
Absolutely,
and here
absolutely.
we are doing 45, 50, 70, and we
Mhm.
no idea about how to analyze and put it down on
Yeah.
paper.
You have Priya sitting here with you, although she's not here, but she is here. She's one girl I admire a lot, because she's one person who has been very analytical and has actually instilled a lot of enthusiasm and this kind of a feeling amongst her juniors. I do try on I mean, I also say the same thing, because in every meeting I make it a point to present some Indian data. From wherever I may get it, but I do present it, because we need to show that we have evidence. We
Right.
need to
Yeah,
have,
yeah.
we do need
We
to
do
show
have
that.
evidence and we
We do
work
have,
on
and
and
we
we
have
work
to
on it.
create evidence, Punita. We have to create evidence.
Yes,
Unless and unless we create that or show that, showcase it, nobody's going to believe us, no? So that
absolutely.
is why. And I give 110 marks to all you endoscopic surgeons, because you really raised the bar of surgery, endoscopic surgery in the world. Indians are now recognized as one of the finest surgeons in the whole world because of you all. And look, it just tells you that, okay, here, but you people have also recorded it. Even though it is mostly videos, but not so much of so many publications that should have been the kind of work that you all are doing. But still,
Exactly.
but
Yeah.
still, you have reached that level, but that
No,
is amazing.
I think every aspect of reproductive medicine is improving, and
Absolutely.
and I think Indians are very pig-headed about just putting their head down and getting down to doing things. I
Yeah.
see in the Western counterparts they become lazy. A lot of
Yes.
centers are doing good, but I
Uh,
feel here in India, small centers doing laparoscopy are doing wonderful
absolutely.
job.
Absolutely.
There was a time when no one was doing it, but now every nook and crony has a endoscopist, who's
Yes,
doing
yes,
good
yes.
work.
Good work. Yeah.
That
That is
I feel is
important.
good for reproductive medicine also. Plus, it runs hand in hand. The
Yeah.
reproductive medicine can't do without endoscopic surgery, and vice versa.
Absolutely.
So
True.
I
Very
think a
true. Very true.
parallel improvement in wider
All
care,
aspects has been,
help the
ultrasound has helped us because we can see inside. Seeing is believing. And if you can see, and you people are the gold standards, you have made us see through a keyhole. So, all
No,
all
but I think ultrasound as a tool for an IVF person is fantastic. The way they handle their follicle monitoring and everything they're doing on their own. So
we
it,
can't do
it
it.
is
We can't do without it. It's an extended internal examination for us now.
exactly.
Yeah.
So you make it look so easy, and it is so adaptable that it is a part of the curriculum of reproductive medicine that
True.
you have to know about the ultrasound. My,
The only thing is with all this happening, and I think because of the population explosion also in the country, because of the number of doctors increasing competition, which has made the juniors very impatient, and they want to learn everything, because they have to grab patients, as I would say. We never had to do that. We were never
yeah, you
struggling
have
to
the
get
beginner's
patients.
advantage. You
We
have the
had the
beginner's
business.
advantage.
But again, Punita, we didn't have so many patients. It's not as if our OPDs were overflowing. It wasn't like that. We had a
You worked
decent
hard
number
for
of
every
patients. Yeah.
patient that you have.
That's
So
all. So
I think
basically, that is one thing that everybody has to learn, that, Rome was not built in a day, as they say. And so
exactly.
also medicine is something which goes on and on. And I think it will go with our, I won't say graves, with our funeral pyre, all of us.
No, yeah. I've always seen you people working so enthusiastically, being there for every forum, being there for all youngsters. Thank you so much, Dr.
Thank
Sonia
you very
Malik. It was
much.
a
Thank
pleasure
you so
interacting
much.
with you.
Thank you.
And what
Thank
an
you for this very,
inspirational journey you've had. Thank you
thank
so
you
much.
so much for this very interesting, conversation with you all. Thank you so much. Thank you for inviting me. Thank you.
It was a pleasure. Thank you,
Thank-
Priya. And thank you, Deepika Jagsonpal.
Thank you,
For-
Priya. Thanks a lot.
Thank you,
Amit
Sonia, ma'am.
and Deepika have been with me for a very, very long time.
Oh, yes, 24 years, ma'am.
There you are. See, a long journey
Wow.
together. Right from the time Jagsonpal came in, we were there together.
Right. Thanks.
Right,
Thanks
ma'am.
a lot.
Thank you. Thank you, Dr. Punita, ma'am, and all the faculty and the attendees present with us today. Thank you very much.
Thank you, Deepika. It was a wonderful session. I'm glad you could host this for us.